So we're going to move on to muscle-invasive bladder cancer. Welcome Dr. Yen to the stage. He's our partner in GU Medical Oncology. I work with him at the VA. Dr. Lerner and Dr. Godoy work with him extensively at Baylor as well. So we're very glad to have him here with us. Again, disclosures, multiple clinical trials that we're all involved in. Case one, we're going to have two example cases here to give us some fodder for discussion. But we have a 57-year-old man with gross hematuria. He has normal renal function, but was a former smoker. TURBT showed T1 high-grade multifocal CIS. He did not have re-resection. You would note there's no mention of the muscle status in that pathology. The urologist recommends BCG. The patient seeks a second opinion. He does undergo re-resection upon seeing the second urologist, and this TURBT confirms muscle-invasive disease as well as carcinoma in situ with multifocal lymphovascular invasion. Where to go next? As the guidelines would say, he should have neoadjuvant chemotherapy and radical cystectomy as the treatment of choice. As another example, I have a 66-year-old man who has a remote history of colon cancer. He did previously undergo chemo and radiation and a low anterior resection. He then presents almost 15 years later with a tumor in the anterior wall of the bladder that comes back as T2 high grade. It shows urothelial carcinoma with extensive squamous features but no lymphovascular invasion. And now what to do? He also undergoes or is advised to undergo neoadjuvant cisplatin-based chemotherapy plus celecoxib. So in terms of integrated treatment options, please, Dr. Lerner, take us.
So just this first case, first patient is one of mine, and it serves as a reminder that please, we can't make treatment decisions in a patient with a high-grade T1 tumor based upon an initial TURBT. That patient has to go back for a re-resection. Most of the time, I would say, and even in my hands, you know, we haven't necessarily sampled the rest of the bladder to look for CIS, so that second resection gives you an opportunity to go back and not only re-resect, make sure you've got muscle, and also sample the rest of the bladder to look for CIS. And I've got lots of examples of this patient who obviously would have been very inappropriate therapy to get BCG based upon that initial TUR. Just for historical purposes, preoperative radiation doesn't really have a role. There were lots of randomized trials done, and the only positive studies were in squamous cell in Egypt. But that's not really part of our contemporary treatment. Obviously, we have an option to give chemotherapy either, in this case, before cystectomy or after cystectomy, advantages and disadvantages to both strategies, but the evidence really is around neoadjuvant, and until recently, the majority of patients, the overwhelming majority of patients, were not getting this guideline-based, level 1 evidence-supported therapy. There was more adjuvant being done than neoadjuvant. However, today, and that's upwards of 50%, and at least in some, I would say, academic centers, I've seen as high as 70%. So that means that the urologists were drinking the Kool-Aid and obviously establishing closer ties with our medical oncologists and doing multidisciplinary team evaluation to try to get the right treatment for these patients. And just it serves as a reminder that, and we'll get into this a little deeper, that the level 1 evidence really supports only platinum-based chemotherapy. So I operated on a guy yesterday, older patient, and with some comorbidities, who had gotten gem-carbo in this same setting and basically had no response. So one could argue in that setting, we'll get into this, that maybe he should have gone straight to cystectomy if there was a feeling that he wasn't platinum eligible, or given him platinum if he met all the criteria for receiving that. This is one of the two studies that provided the level 1 evidence supporting cisplatin-based neoadjuvant chemotherapy. This was a SWOG study that randomized patients to 3 cycles of MVAC plus cystectomy versus cystectomy alone. You can see the Kaplan-Meier plots, you can see the statistics, and this in a trial that was done in Europe, largely in Europe, those two trials together established this as a standard of care. There are other randomized trials that were done in this disease space. If we as urologists have any question about the efficacy of chemotherapy, just compare the pathologic complete response rate in the combination arm versus the cystectomy alone arm. We know that with TURBT, we often render, some of the times we render our patients pathologically free of disease. That number's about 12 to 15%. Those patients tend to do really well, but there's a near tripling of the path CR rate with the platinum-based chemotherapy, showing unequivocal evidence of the benefit of chemotherapy, at least on the primary tumor. And of course, the presumption is that you're seeing a similar effect in micrometastatic disease or small volume nodal disease. There have been attempts to risk stratify. There's no question that we're treating a lot of patients who aren't going to benefit from the treatment. If only 40% are getting a path CR, and there's probably some benefit to people who have only residual TATIS or in some cases PT1 disease, let's say that's 50%. So you've got basically a 1 out of 2 chance of benefiting from the chemotherapy. That means half the patients are getting toxicity without benefit. And as you know, the toxicity sometimes is not trivial, and in rare cases can be life-threatening. So there's been attempts to risk stratify to try to enrich a treatment population with patients who are most likely to benefit. This is work from MD Anderson. You can see the bullet points there. And these are all patients who would be more likely to have locally advanced disease, either T3, T4, or node metastatic disease. And you see some of the micropapillary and small cell, which are particularly aggressive variants of high-grade cancer. These are the Kaplan-Meier plots from their publication that included validation in a USC cohort with Sia Danishman. We took a look at our own data in a smaller study and showed something quite similar, that even if you started out at low risk and pathologically were upstaged to high risk, you still had a better outcome than if you started out at high risk. But this is not validated. The standard of care is still all comers, and hopefully some of the clinical trials that are being done now will get us closer to that. The other thing is that, well, my patient has just a small clinical T2 tumor, maybe I can just go do a cystectomy and they don't need chemotherapy. But in the SWOG trial, the benefit accrued to both groups of patients. And I can tell you stories about someone who I thought was low risk, did a cystectomy, turned out that they were high risk, and they just progressed right through that and died. And perhaps in part because we weren't aggressive enough in offering neoadjuvant chemotherapy. So it's the standard of care for muscle-invasive, essentially a non-metastatic disease. And there's some data to show that low-risk patients do benefit from neoadjuvant chemotherapy just as much as we perceive that the high-risk patients do. And this paper was published recently in 2017. And so I think that we really are not in a position today to sort of cherry pick or risk stratify in patients who are otherwise platinum eligible. And so Ed will tell you that every single one of our patients, he or one of his colleagues evaluates when we're presented with a patient with muscle-invasive bladder cancer, so that they get a good multidisciplinary evaluation. Now, arguably, the margin of benefit is small. The absolute benefit is probably in the 5 to 10% range. And in terms of when you look at platinum-based combination chemotherapy regimens, so essentially that's MVAC or gemcitabine cisplatin, but this is the same margin of benefit that you see in other organ site cancers, breast, colon, for example, where neoadjuvant or adjuvant has been the standard of care for quite some time. This is the survival curve, and again, it doesn't look much different between the two arms, but that 5% or 10% absolute difference may be life-saving for an individual patient. Our guidelines strongly support this. There is no hesitation. The only challenge is that the two-drug combination of gemcitabine cisplatin has never been tested in a randomized phase 3 trial in this setting. The data for using that comes in metastatic disease, but it's highly likely, and I'm curious to see Ed's thoughts, that if you're primed to respond to platinum, you may respond similarly to MVAC or GC, even though the drugs in there are different. And there's probably some differential response as well, but that's currently being used quite a bit.
So we have established we are giving cisplatin-based chemotherapy followed by radical cystectomy or cystoprostatectomy. However, we could have a different case. This is a 75-year-old male with gross hematuria. He is a current smoker, 100-pack years. He does unfortunately have chronic kidney disease with an estimated GFR of 48. His TURBT shows T2 urothelial cancer. This is a broad-based asymmetry here of his bladder wall on CT urogram. And we should note, Dr. Yen will tell us some about eligibility for cisplatin.
Yeah, so Seth already went through a lot of the evidence supporting cisplatin-based combination chemotherapy for neoadjuvant treatment. So I'm going to kind of approach this from a different standpoint. But we'll go over first about eligibility for cisplatin-based therapy. As you know, cisplatin has renal toxicity and it's eliminated through the kidney. So having adequate renal function prior to treatment is very important. We based this off of GFR, creatinine clearance, kind of depending on the setting or the clinical trial. But oftentimes, GFR, creatinine clearance above 60 is sort of considered acceptable for standard dosed cisplatin-based doses of 70 milligrams per meter squared. If your GFR is a little bit poorer than that, but not too much poorer, basically in the range of 50 to 60 liters per minute, we often consider split dosing cisplatin chemotherapy, usually split dose cisgem, and oftentimes we'll try to do some more hydration or other treatment considerations to kind of help their kidney function or minimize the amount of cisplatin-based toxicities. Now, under 50 milliliters per minute, we usually, for a lot of clinical trials, that's often sort of the cut point where we decide that people are cisplatin ineligible. In practice, sometimes I'll go even as low as 45 or 40, but that's a rarity. Cisplatin-based chemotherapy can also cause neurotoxicity. We often know about that in terms of peripheral neuropathy, but there are definitely patients who have tinnitus. And if they already have a substantial amount of sensory neural hearing loss prior to onset of chemotherapy, I often have to have a discussion with the patient. I generally don't see a lot of sensory neural hearing loss with just 3 months of chemotherapy, but sometimes it could be very, very impactful. I have seen some cases where tinnitus is very, very severe. So functional status is also a very important thing. This is hard to kind of measure, but in general, the more debilitated a patient is, and less likely they're going to be able to tolerate cisplatin. And you have to think about being able to get the patient through a full course of neoadjuvant treatment and not really just one cycle or so. So that's very important because you set them, you give them expectations about trying to start them on chemotherapy, and if they really can't even make it past short of the first step, it doesn't really help them. It kind of just delays their ultimate treatment. Overall, our studies show us basically about 40 to 50% of patients are considered cisplatin ineligible. So what about carboplatin? Carboplatin is sort of the next gut reaction step in terms of finding an alternative for cisplatin if your patient is not a candidate for cisplatin. Carboplatin is an active agent in bladder cancer, but the problem with carboplatin is that there's not really a lot of neoadjuvant studies, definitely no high-level evidence that shows that not only is it non-inferior or equivalent to cisplatin or cisplatin-based combinations, but basically there might be even some inferiority. So if you, the references are there, but you can see that there are some trials showing that carboplatin is active. There are also trials that show that it's not very good. Probably the most recent study I thought was compelling was this one listed here. Was a retrospective review, I think out of Florida, looking at patients who were getting cisgem versus Docent's IMVAC or CarboGem. And the patients who got the alternative of CarboGem definitely did not do as well. They're in the metastatic setting as well. Carboplatin seems to be, there's definitely some data showing that carboplatin may be inferior.
So in the 2019 NCCN Guidelines, neoadjuvant chemotherapy followed by radical cystectomy is category 1 recommendation based on high-level data. However, as Dr. Yen mentioned, some of these concerns about eligibility for cisplatin may not be eligible, and if you cannot give cisplatin-based chemotherapy, you should not give any neoadjuvant therapy. Cystectomy alone is an appropriate option for these patients. Ed, do you want to tell us about some of the other ways that we are studying how we can treat patients in the neoadjuvant setting?
This is investigational, so there have been some two initial studies, small phase 2 studies looking at immunotherapy, one of the new checkpoint inhibitors in the neoadjuvant setting. This one's actually been published using pembrolizumab It was initially presented at ASCO by Andrea Necci, and then the results, this is just a table from the paper, and you'll see that path CR rate of 42% is essentially superimposable on what I showed you before in terms of path CR with cisplatin-based combination chemotherapy. So in terms of initial complete response rate, it's very exciting. Not surprisingly, it's better in patients who are PD-L1 positive versus PD-L1 negative. And Andrea recently showed some survival data, which is very premature, very preliminary, sorry. And there's no difference in survival probability based upon response. So that's going to be a very interesting question about the association of path CR with immunotherapy, and how does that translate to an overall survival benefit. Tom Powles has done a similar study, only reported in abstract form, not published yet, using atezo. And so these are not options available to us now, but not only is single agent IO being studied in the neoadjuvant setting, but now combination chemo IO is going on. So everyone's looking for ways to treat, to find opportunities not just for the platinum ineligible patients, but to improve the outcomes beyond what we have for chemotherapy alone with combination chemo IO.
So Dr. Godoy, as an alternative, we may offer this patient a discussion about trimodal therapy.
Right, so I think it's always something to consider, and it's called trimodal therapy because it involves 3 different steps. The first one, it's a maximum 2 RBT, and if you read the radiation therapy papers, they actually describe a complete 2 RBT, meaning you should resect all the disease that you can see in the bladder as deep as you can, so the bulk of the disease as much as possible. And then treatment is complemented with radiation therapy, and goes along with a sensitizing systemic chemotherapy. And you see many different agents have been used for this, including cisplatin carbo, 5-FU, paclitaxel, low-dose mito, low-dose gem. And the goal is just to sensitize the cells and keep the cells a little more fragile, so chemotherapy will be more effective. And this is typically often for patients who refuse cystectomy, or they are not fit, they're not healthy enough to undergo the procedure. Although we tend in our practice to offer to every single one as a possible alternative for them to consider, then you have to go a little bit on pros and cons on differences. But the keys to the success of the trimodal therapy, of some people prefer to mention as a bladder preservation protocol, is first of all patient selection. Selection, that's the key to success. And I'm going to go into some of the factors that might render some patients not so ideal for this. Great multidisciplinary team coordination, because as you see, it involves the intense participation on the surgeon, the radiation oncologist, the medical oncologist. We need to coordinate our treatments, our schedules, and the treatment very closely. We have to be in close communication to see how patients is faring with all 3 modalities. And also, we need to keep a close follow-up in terms of surveilling this bladder, doing biopsies, and monitoring this bladder, because part of this, for patients who have partial response only and don't seem to be responding completely, is actually proceed with a salvage cystectomy in those who are medically fit for it. So that's part of the algorithm and should not be forgotten, and that's an important component out of it. And it happens in about 10 to 15% of the cases. So for those who argue in favor of bladder preservation protocol, the main argument is that, of course, organ preservation, it's a very strong paradigm, is attractive in every single organ site. We discussed earlier about the morbidity of the cystectomy. It's a life-altering operation when patients have to adapt to changes in terms of the urinary diversion and the looks and the health status and the things they need to do on a daily basis. There's a high rate of a 90-day complication. Some of these patients progress into a decrease in renal function, and they go into a chronic kidney disease status. About 50% of the patients can be ineligible for radical cystectomy just because they're not fit enough for surgery, or they decline surgery, or other reasons. if we put together, I'm not going to show the survival and the data for the Trimodal therapy data here, but considering that would be a similar oncological outcome, patients who have a better urinary and sexual function, improved quality of life, and also self-esteem, and that would avoid cystectomy in about 85%. So that seems very, very attractive. But again, selection of the candidates is actually the key to this story. And again, the inability to achieve a complete resection endoscopically, a complete TUR, a very maximum TUR, will impact how this whole protocol is going to work. The presence of hydronephrosis or the very large tumor burden are shown as risk factors for poor results. Extensive carcinoma in situ, we know that disease does not respond very well to chemo and/or radiation. Presence of high tumors in diverticulums are always tricky to resect, are always tricky to move out of the way. Partial cystectomies can be included in this protocol, so patients can undergo a partial cystectomy, especially in these situations, and then continue on with the chemosensitizing radiation therapy. Extensive involvement on bladder neck, especially on women, is also being shown to not respond very well. Inability to tolerate, of course, the chemotherapy or the radiation therapy if you can complete the treatment. And the patients with a previous pelvic radiation, poor baseline bowel function, bladder function, of course, they will have a limited capacity of how much radiation, how much treatment they can get. So all those things are very important to consider, and the selection in these trials would exclude these patients from their participation. Again, to emphasize the role of the TURBT, so every time we're dealing with these tumors and we're considering possible not going for cystectomy but for trimodal therapy, when I'm doing the resection, I tend to do a maximum complete TURBT up front, so the patient will be ready for it anyways, and you can see the benefit of doing that both on a disease-specific survival or your left side curve, as also an overall survival on the right side of the curve. So in the absence of a level 1 evidence data comparing directly the trimodal therapy versus radical cystectomy, it gets a little harder for us to have strong recommendations either way. What I want to spend a couple more minutes is just to go over the emerging data that's coming from retrospective studies looking at oncological outcomes and also costs, comparing trimodal therapy versus cystectomy alone, and it seems that on those studies, surgery seems to have a benefit in both areas. And of course, there's roles for new biological markers, new genomic markers and stratification that are coming up. The incorporation of immuno-oncology therapies in this scenario. But I would say I think the trimodal therapy has a definite niche in this disease. We see quite often patients who either completely decline a cystectomy or they're not fit enough for cystectomy. So in those situations, at least, it will be really helpful to have those protocols in place. So this is the data, and it's coming from PLOS and also JAMA a couple months ago. This, for example, is a systemic review meta-analysis, large populational data, and you can see on top of your screen the description of the studies in terms of disease-specific survival under trimodal therapy. At the bottom, you can see how these studies lump towards favoring cystectomy to the right side of the plot. Same thing for overall survival. If you go towards the SEER database, there's 2 studies showing oncological outcomes and costs, and you can see those are all propensity scores matched, so very, very well done populational studies, and apparently radical cystectomy alone has had an edge in terms of improved survival and also favorable costs. In this plot, you can see that, of course, cystectomy will be more costly in terms of the hospitalization and admissions and surgical costs, and also the surgery directly. But in terms of pathology, lab, radiology, other medication expenses, then radiation takes an edge. This data does not include the use of neoadjuvant chemotherapy, so this is something to take in consideration as well. If you include neoadjuvant chemotherapy plus cystectomy and put them together, then these graphics change quite a bit. And this is just to show you numbers in terms of within a year of costs from radical cystectomy alone and trimodal therapy. You can see in terms of increment effects and looking at overall survival and also intensity of treatment, how the numbers can add in terms of thousands of dollars in the last column. Just to mention, SWOG is getting this trial. Very interesting concept because it's putting forward this strategy of offering trimodal therapy for patients with a muscle-invasive bladder cancer, but also it's studying the concept of introducing an immuno-oncology drug, which is a tislelizumab, to this mix and see how this is going to add to benefit. So this is the study schema. The primary endpoint is a new primary endpoint for many of you, I think, is BIDIS. That means bladder intact. Disease-free survival means it's the length that the patients have with the bladder without tumors, without cystectomy, so the bladder is intact in there and healthy. As you can see, the statistical design, this is planning to almost 500 patients, accrue 4 years, total 7 years to complete, but I think it's going to be a very important clinical trial to in a randomized fashion, give us level 1 data to understand more how those patients fare with duration therapy and hopefully better outcomes, including the immuno-oncology.
So for this patient for any patient with muscle-invasive bladder cancer that is non-metastatic, some of the important things to remember are to try to cultivate relationships with your medical oncologist and your radiation oncologist. Trimodal therapy for bladder is very different than prostate and does require some expertise and some knowledge between all of the involved clinicians. Multidisciplinary discussion of every patient with newly diagnosed muscle-invasive bladder cancer will also help further the treatment for each patient, and do try to be aware of cooperative group or other clinical trials available. Just as an editorialized statement, there may or will be a time when not all patients will be advised to undergo radical cystectomy, and we will have confidence in alternate treatment plans. This is our hope, and I'm sure this is our patients' hope as well. So case 4 takes us on a slightly different path. We'll hear some more from Dr. Yen. We have a 72-year-old male with gross hematuria. He was exposed to Agent Orange. He has been a former smoker. His TURBT does show muscle-invasive bladder cancer. His exam under anesthesia shows a 3-dimensional mass on the right side, which you can believe based on this CT scan. But he also does have lung nodules, which indicate distant metastasis on his staging imaging. So, Dr. Yen.
Yes, so as we already know, urothelial cancer is definitely a life-threatening cancer in worldwide and also in the U.S. Annually, there are about 200,000 people who are going to die from urothelial cancer, and then in the U.S., a little bit more than 17,000 per year. Our go-to first-line therapy is typically a cisplatin-based or a platinum-based combination chemotherapy regimen, which offers basically about a 14 to 15-year prognosis. After the patients fail this, though, their prognosis is further limited down to basically about the range of 4 to 7 months. So immunotherapy is no longer a new topic for bladder cancer any longer, and if I had to give a comprehensive review about immunotherapy, we'd probably be here for a longer period of time. So for the purposes of this talk, I was really going to try to focus on just a summary of all the key clinical trials with immunotherapies and basically leading to the results of what's approved in terms of immunotherapy for bladder cancer. So just some basics here. Checkpoint inhibitors are either antibodies targeting PD-1 or PD-L1. PD-1 stands for programmed death 1, which is a receptor on T cells. PD-L1 is the ligand that it binds to, is typically found on tumors or the cells in the tumor microenvironment. The binding or interaction of these two basically downregulates the T cell activation, which helps the cancer cells evade the immune system. So earlier cancers, earlier trials prior to when these were being tested in bladder cancer patients, such as in kidney cancer and also melanoma, they were very promising in terms of response and some early survival data. So it was a logical next step to go on to trialing these in bladder cancer patients. So the earliest clinical trials using checkpoint inhibitors in urothelial cancer patients were mainly multi-cohort trials. And these were trials looking at checkpoint inhibitors in all sorts of different cancer types, including bladder cancer. So as you can see here listed are two of these with pembrolizumab and atezolizumab. And overall, the primary endpoints were generally looking for activity in these cancer patients and also evaluating the safety margins. As you can see here, in the bladder cancer patients who were enrolled onto these cohort trials generally had a lot of poor risk. And these included older age, poor performance status, also a significant number of them had kidney dysfunction, and quite a few of them also had multiple lines of therapy as well as visceral disease. Basically, initial findings from these trials showed that checkpoint inhibitors the treatment with these checkpoint inhibitors were safe and tolerable. They did, in fact, show activity in a heavily pretreated population with poor risk features. And interestingly enough, the responses were seen in patients who even had 0% or low expression of PD-L1, which was felt to be a predictive marker. So the trial results from these studies eventually led to, of course, clinical trials involving just bladder cancer patients. And there were a whole wave of these. And these included the ones with atezolizumab, nivolumab, pembrolizumab. As you can see here for atezolizumab, IMvigor 210, 211, for nivolumab, checkmate 275, and pembrolizumab was evaluated in Keynote 45 and 52. I added also on two other trials here, Javelin and Study 1108, that was looking at avelumab and durvalumab. But in general, these trials were looking at responses in two different populations of bladder cancer patients, and these included first-line treatment in cisplatin-ineligible patients. And the second population was basically those who had progressed or had refractory disease after a platinum combination. So starting with the cisplatin-ineligible patients, I'm just going to highlight the two trials listed here. One was IMvigor 210 and also Keynote 52. IMvigor 210 was actually a two-cohort study. They were looking at two different populations, the ones I described earlier. Cohort 1 was just with the cisplatin-ineligible patients, and quite a few of these people had renal dysfunction. Next slide. Anti-tumor activity was the primary endpoint in IMvigor 210, and what you see on this slide here is actually the activity broken down by PD-L1 expression. In this trial, they subclassified them into immune cohorts. That's what IC stands for, and that would be basically 0, 1, and 2, and 3. So as you can see, patients who had higher expression levels of PD-L1 tended to have more responses. The complete responses were in dark green here, and also the partial responses were in light green. But what's also very striking here is that you can also see not only partial responses in the people who had 0% PD-L1 expression, but there were actually some patients who also had complete responses, which is very impressive. So IMvigor 210 was updated at ASCO 2018, and after a median follow-up of 29 months, in cohort 1, the overall response rate was 24%, and overall survival, the median overall survival was 16 months. And there were definitely late responses seen. What was notable also was that the median duration of response was not reached yet. At 1 year, basically 58% of the patients were still alive. So this showed us that checkpoint inhibitor treatments offered a durable and tolerable treatment for advanced disease. Pembrolizumab was also evaluated in a cisplatin-ineligible patient population in Keynote 52. And overall, you can see that the results were pretty similar to the one with atezolizumab. Overall response rate in this trial was 28.9% after a median follow-up of 11.5 months. The survival here was 11.5, a little bit poorer than the earlier trial, but that was probably because of some differences in the patient selection here. As you can see, 85% of them have visceral disease. But overall, the results were pretty much the same. Also, what I wanted to point out here is that the response rate and also the survival was bumped up in the population of people who were PD-L1 positive. So approaching 50% in the PD-L1 positive patients, the response rate, and also for survival, it was approaching 18.5 months. Pembrolizumab was also evaluated in the second-line setting in patients who had failed a platinum combination before in the Keynote 45. This was an interesting trial. This was a randomized trial, a phase 3 trial, looking at pembrolizumab versus dealer's choice of 3 different types of chemotherapy. In the US, it was docetaxel or paclitaxel. In Europe, they used vinflunine, which was approved in Europe. And here we see the co-primary endpoints of that trial: overall survival and progression-free survival. And you can see from the Kaplan-Meier curves, there was a significant favoring of pembrolizumab over whichever chemotherapy. Overall survival here favored pembrolizumab 21% versus chemotherapy 11%, which is pretty comparable to historic rates. Survival here was also favoring pembrolizumab by 10.3 months versus 7.3 months. So in summary here, looking at all the different checkpoint inhibitor trials in metastatic urothelial cancer, across the first sort of group of rows here. In the second line setting, you can see the response rates offered by checkpoint inhibitors border basically about 20%. And there are definitely some complete responses seen here in this poor risk population. And overall survival kind of approaches basically about 7 to 8 months, which is also better than what we see with second line chemotherapy options. In the first line setting, in only cisplatin ineligible patients, pembrolizumab and atezolizumab have been evaluated here, and the response rate kind of goes up to approaching 25–30%. Overall survival here is basically more than a year, approaching 16 years at best in the atezolizumab arm. Also notable here is the rate of grade 3 side effects. You can see overall that overall the number of percentage of these grade 3 side effects were low, especially compared to chemo. Adverse events. Overall, they're very well tolerated. We often see fatigue and maybe some arthralgia or rash, but I don't really see too much more beyond that. There is definitely a small segment of these patients who will have an infusion reaction, usually within the first 1 to 4 doses of any sort of checkpoint inhibitor, so always be on the lookout for that. But overall, grade 3 side effects, again, were low. Immune toxicities are also very rare, but when they happen, they can be very, very serious. It's important to identify these earlier on and start management immediately. These include often, we describe pneumonitis and transaminitis. Rash is generally not that bad. I have seen a couple of hepatitis and hypophysitis cases, which can be actually lethal. But overall, the take-home message here is that compared to chemotherapy, it's a lot more tolerable. So, of course, the FDA has approved a number of these agents for metastatic patients. In the second-line setting, 5 of these have been approved. And then in the first-line setting, atezolizumab and pembrolizumab have been approved in only cisplatin-ineligible patients. So future directions, I kind of had to take a breath and stop from giving too much information here because there's a lot of exciting trials that should either in the very near future or maybe a little bit soon after that to be reported. But checkpoint inhibitors are being evaluated all across the board in multiple different formats. In the frontline setting, we're now looking at the age of doing combination trials, and some of these are paired with chemotherapy. Some of them are actually paired with immunotherapy, sort of like a double immunotherapy. Maintenance is also being looked at, especially switch maintenance. If people have finished sort of 4 to 6 cycles of platinum-based therapy, should we offer earlier checkpoint inhibitor treatments for these patients, or should we give them a break? So there's 2 trials looking at that here. And other directions include also the trials, some of them we talked about earlier, neoadjuvant and adjuvant immunotherapy trials, immunotherapy with chemotherapy and radiation, immunotherapy perhaps with new targeted agents, like for example erdafitinib that was approved earlier this year, and also immunotherapy and whether or not it has a role in non-muscle invasive disease. So the takeaway message for metastatic muscle invasive bladder cancer, since the first approval of a checkpoint inhibitor in bladder cancer, the treatment landscape of bladder cancer has changed dramatically and will continue to do so in the following years. 5 checkpoint inhibitors are approved for second-line therapy in metastatic urothelial carcinoma, and atezolizumab and pembrolizumab are approved for first-line therapy in metastatic urothelial cancer cases in patients who are cisplatin ineligible if they have high PD-L1 expression or if they're unfit for any platinum combination.
Thank you, Dr. Yen. So we're almost to the end of our discussion time. We went into that time with our extensive consideration of all of these fantastic agents that are newly on the market for bladder cancer. Does anyone have any questions?
So 2 one for Dr. Yan. Does split dosing impact cancer outcomes? And the second question for Dr. Godoy and Lerner, what's the role of a maximal TUR in somebody who you know is going to go on for chemo and a cystectomy?
For the first question, I don't think there's any high-level evidence showing that it does. And oftentimes in clinical trials, if there's borderline renal function, split dosing is allowed.
Second question, what's the role of a maximal TUR in a patient who's ultimately going to go on to a cystectomy? There's no data, is the short answer. And there's a very interesting trial that Jim Cato is doing in the UK where I'm pretty sure what they're doing is just a biopsy in the office to establish grade and histology. They're doing an MRI for staging and then hitting the go button on treatment. So that's not even a TUR, that's a biopsy. It's interesting to me that there are experts in our field who claim that there's a benefit, but I don't see a compelling reason not to do maybe not a maximal or necessarily a complete resection, but more importantly, to not take any risk in terms of full thickness resection of the bladder, a perforation in the setting of an obvious high-grade invasive cancer.
Yeah, no, I agree. The same thing. You know, in the lack of data, we know that patients who undergo neoadjuvant chemotherapy do better if they achieve PT0 status by the time of cystectomy. So considering that, and considering that by the time you're resecting, you may not know if the patient is really going to go towards cystectomy or trimodal therapy, I tend to be more aggressive up front on that resection, kind of prepare for both scenarios. But there's no data. But my rationale is if you help chemotherapy debulking as much as possible, leaving the minimum possible burden behind for the chemotherapy to complete the job and render T0, those patients will do the best. But of course, it needs to be in a safe environment, not going beyond the walls, birthing, because then you're not achieving anything else.
Yeah, I would just say that if the patients we know do the best are those that achieve PT0 at the time after cisplatin-based chemotherapy and cystectomy, then everything I can do to help that patient achieve PT0, I will try. Thank you very much.